All right, we are here joined by Dr. Michael Auriemma. He is a double board certified physician in both physical medicine and rehabilitation and also sports medicine. He specializes in the diagnosis and treatment of both acute and chronic musculoskeletal and sports related injuries. His practice, he uses a lot of ultrasound for both diagnostic and treatment. And he also includes advanced orthobiologics and regenerative medicine techniques, which big words we're going to dive into in a little bit here. He's also a member of the American Academy of Physical Medicine and Rehabilitation Orthobiologics Work Group. And again, we're going to dive into those things. So he's very dedicated to advancing the field of regenerative medicine. And so, Mike, thanks so much for joining us.
Jesse, thanks for having me. It's a pleasure to be a part of this, and hopefully this will be an informative session for everybody.
Yeah, this is great. So, we're a physical therapy company that focuses on people staying active and exercising. So I always like to ask, if you could only do one form of exercise for the rest of your life, what would it be?
Sure, yeah, and that dovetails perfectly with my passion as well. If I could only choose one thing, it would be some form of circuit training. So the ability to be efficient with my workouts, I am not immune to the same pressures that a lot of my patients and a lot of your clients probably are, where we don't have an infinite amount of time. So as efficient as I can be, getting some component of strength training and a cardiovascular component, that is where I lean, and I try to involve a lot of compound movements so that, again, I'm hitting on the efficiency. But it would be some form of a circuit train. So I'm getting from one move to the next and hitting as much as I can and being efficient.
That's great. Yeah, as a physician, first of all, and someone who just opened their own practice, I'm sure efficiency is probably number one most important thing when it comes to your workouts these days.
Absolutely. There are a lot of hats to be worn, and it's easy to find the excuse to say there's not enough time for it, but you got to find a way to squeeze it in when you can, and even if it's a piecemeal here and you can get more later on, that's the struggle that we live. It's a first world problem, but it's a problem.
Yeah, I love that. I saw some research lately, and I've been kind of talking with my clients more about this, about you don't have to have an hour block of exercise. If you do 15 minutes in the morning, 15 minutes at lunch, 15 minutes afternoon, that adds up throughout the day. So I think that's great.
No doubt. Yep.
All right, so your bio is awesome, but a lot of big words in there that some people might not kind of understand. So tell us a little bit, physical medicine, rehabilitation, orthobiologics, in short summary, or as short as you can get, still being thorough, what exactly is it that you do to help people?
Sure. Yeah. Let's unpack some of those terms in there. So the first one is physical medicine, which is also known as physiatry, or for some of my peers, they're very big on saying they're a physiatrist. That's born out of the fact that physiatrist sounds relatively similar to psychiatrist, and it was just trying to differentiate these things. So physical medicine and rehabilitation is a vast field of medicine. So individuals like myself, we more or less function as non-surgical orthopedists. So we really focus on musculoskeletal medicine, sports medicine, how the body moves and functions, and really physiatry at its core is an emphasis on function. It's not just looking at pictures. It's looking at how somebody functions in the larger scale. But physical medicine and rehabilitation as an entire field is vast, where you'll see individuals that focus on brain injuries, spinal cord injuries, post-stroke recovery. There's a pediatric realm of physiatry that will focus on a lot of movement disorders. So the PM&R is a vast field. Within that field, some of us are very generalist, others are more hyper-focused, and my focus over time has been more on the sports medicine, functional movement side of things. I did a sports medicine fellowship after my PM&R residency in order to gain that additional training. That entails a lot of diagnostic ultrasound work and using ultrasound as an extension of our physical exam. So if someone's unfamiliar with ultrasound, it's a handheld device that when run over the body can present a picture into the body and allow us to look at soft and hard tissues, the muscles, the tendons, the ligaments, the outline of the bones. So it gives us some point of care diagnostics where we can get some immediate feedback on what might be ailing somebody, and being able to immediately correlate that to a physical exam as opposed to having to send for imaging. Now, it doesn't completely obviate the need for other imaging. Sometimes X-rays or MRIs or CT scans, CAT scans are necessary to complement what we can see in the office. But having that real-time extension of our exam can be extraordinarily useful, and it's very rewarding for not just myself, but for patients when they're able to see that in real time, and I can point out, hey, here's what we're looking at. And then on the orthobiologic side of things, so orthobiologics refer to substances that come from one's own body that we are able to use in order to attempt to initiate some type of a healing or reparative response. So orthobiologics overlap with regenerative medicine. Regenerative medicine is a term that's been around for quite a while now. Sometimes the connotation of regenerative can be a bit overly optimistic. I think it's common to picture a chameleon or the lizard whose tail gets lopped off and then that tail can grow back. And we really don't have point of care biologics that function at that level, but we are able to tap into the body's repair mechanisms in order to initiate reduction in pain, improve function, greater stability, depending on the injury or abnormality we're using it to target. So orthobiologics is that subset of regenerative medicine that uses a substance from one's own body. Some of the common substances, and maybe I'm jumping too into the details, you stop me if you want me to. Some of those more common orthobiologics would be things like platelet-rich plasma or PRP, which is a process where we'll draw somebody's blood, spin that down to concentrate the growth factors from the platelets, and then inject those growth factors and platelets into an area of interest, whether it's an arthritic joint, a sprained ligament, an abnormal tendon. And then there are advanced cellular therapies, which are commonly referred to as stem cells, though we try to get away from that moniker as much as we can. If you go overseas or you enroll in an FDA registered clinical trial, you might be able to encounter true stem cells where somebody will harvest them from your body, grow them in a lab, isolate them, then grow them in a lab to an exponentially higher number, and then re-inject somewhere. But with the current FDA guidelines, if you're not under a registered trial, that's not something we're legally allowed to do in the US. So what we can do by way of advanced cellular therapies is we can take tissues that have a relative propensity of stem cells, such as adipose or fat tissue or bone marrow tissue. We can minimally process those through rinsing or resizing techniques and then re-inject them into a similar area of interest. And these are products that have some degree of stem cells, but other growth factors as well that might be ramped up compared to PRP, and we can use them for clinical applications as well. So those would be the most common biologics used in the orthopedic physiatry realm. There's other forms of regenerative medicine, but they would not meet the technical definition of a biologic.
Got it. Okay. So biologic is basically using someone's own cells, own blood to kind of stimulate the healing process. Is that a kind of a very broad summary?
Yeah, that's a good summary. And technically, you could use products that come from another being as well. Now, right now, that again would not be within what the FDA permits. So if you go back as recently as 4 or 5 years, there were quote unquote off the shelf stem cells that could be used that would come from various amniotic or birth tissue products. The reality is that a lot of the studies that looked at those products, when they were looked at under a microscope, what they found was that they were more of like a growth factor soup, more in line with what PRP looks like than actual stem cells. The stem cells at that point were no longer viable, were no longer living. That's not to say that those products may not have had some utility, but it completely contradicted or was not in line with what the FDA's guidelines were in terms of what is a permitted biologic to be used. So those products have been pulled from the market. They are likely undergoing review processes as we speak to try to come back to market as an actual drug in terms of meeting the definition of a drug instead of a biologic. But the broad definition of a biologic could include those as well. But I really focus on what we're going to use clinically and what meets FDA standards as of today.
Got it. Okay. And a couple things I want to dive deep on there. One was you mentioned the chameleon and the regenerative piece. I think one thing I hear all the time is someone has a partial tear in their rotator cuff, partial tear in their meniscus, and they think that that tear has to fully regenerate into a fully healthy tendon or a fully healthy meniscus. Can you talk a little bit about whether that happens? Does it need to happen?
Yeah, I think that's a great topic, and that comes up a lot because it's very easy to hyper focus again on the picture. And again, I sound like a broken record probably to a lot of my patients where we treat people, not pictures. The pictures will be informative, can be informative, and can help us guide us where to treat and maybe what treatment to use. But we ultimately, all of our intended outcomes, our outcome goals, which all clinicians and all patients need to be aligned on that. If the patient or client has one goal in mind and the clinician has something else, and this isn't communicated between the two, the treatment is ultimately doomed to fail, or very likely will fail, or will succeed by accident, because you need to make sure that you're reaching for the same goal here. And inevitably, for most people, the goal is going to be something function-based. It's going to be, hey, I need reduced pain so that I can tolerate XYZ. And that's what we're typically aiming for and going for, as opposed to, hey, I want to have the most beautiful rotator cuff tendon in the world. Because they don't always align that way. We all live our lives and accumulate dings and dents over time, and not all of them are meaningful and requiring of treatment. I mean, there's a lot of good literature in the physical therapy world of, hey, rotator cuff injuries of various degrees, you can rehab them, don't need a significant invasive intervention, and can function just fine. So yeah, it's helpful to see these pictures. It's helpful to use these pictures to modify activity when needed, but it is not necessarily the end goal. Now, sometimes there are individuals that the defect in that tendon, let's say, is significant enough that it is the limiting factor, in which case we absolutely should treat in order to try to better achieve the functional goals. But 100 times out of 100, I will take the outcome where somebody is now more functional and in less pain and happy with what they're able to do from an activity standpoint, and the picture still doesn't look perfect, over, hey, this picture looks great, but I'm still in pain and having dysfunction. Why is that? And being dissatisfied with that lack of a functional outcome.
Yeah, I love that message that you're giving people, because what we find often is people think that those two are mutually exclusive. They can't get their function back unless they have this beautiful rotator cuff tendon. So I love that you're telling people, hey, you don't need to have perfectly healthy tendon to have no pain, get your full function back. Sometimes they go together, but they don't have to go together. You can. There's studies that show chronic Achilles tendonitis. People who improve, their image looks exactly the same when they're in 9 out of 10 pain as when they're in 0 out of 10 pain 9 months later. So that's great.
Yeah, I'm totally with you on that. It's tough. I started off our conversation by highlighting the utility of having the point of care ultrasound. Sometimes it can be viewed as a little bit of a detriment, because again, people can become hyper focused on the picture. The other thing is, as we treat somebody and we're progressing along, I will really drive the emphasis to hearing from them, hey, what are you doing functionally? How do you feel? And it's not, when we talk about how somebody feels and what their pain level is, it's not becoming overly fixated on what we could consider the outdated pain scale of what's your pain from 1 to 10. I'd rather know, hey, how does pain limit sleep? How does pain limit, or does pain limit ADLs or your everyday activities? How does it limit your leisure activities or exercise? What were you able to do previously that you can't do now? Or once we start to see progress, what are you now able to do and better tolerate? Like, that is much more meaningful to me. So I will try to steer them towards telling me about, hey, what are you doing now compared to before? How much exercise can you engage in? How long can you walk before the pain comes on, et cetera? And it really guides to that. And the other thing is, and maybe your questioning is aimed at ultimately getting to this, but I might be jumping the line a little bit. I think a huge misconception about orthobiologics, and we got at this already a little bit when talking about regenerative versus repair, just using that nomenclature, is that this is like going out and finding the guy that sold Jack his magic beanstalk beans, right? Like, we don't have that magic bullet that just regrows everything and makes a 73-year-old's knee look like their 23-year-old knee. We don't have that. Are there sometimes case reports or experiences that many of us had where we see a dramatic change in what the anatomy looks like? Yeah, those can happen, but in terms of looking at them like they're the rule, it's just not the case. We're able to use something that can give that extra push in the right direction and stimulate some repair and change what the biochemistry and the cellular anatomy is like around in an arthritic joint or around an abnormal tendon. But when someone comes back to me 6 weeks after a treatment and wants to know, well, does it look better? I steer them back. I say, hey, tell me about how you're feeling. How are you functioning? What are you doing now compared to, the week before we did the treatment? And if we are going to see visual change, it's generally going to take longer to see that, because we know that best science to this point would suggest that, particularly when we're treating soft tissue structures, we're tapping into the body's repair mechanisms that, when we're talking about tendon and ligament and muscle, these tissues pass through an inflammatory, followed by proliferative, followed by remodeling stage in terms of what's happening healing wise. And on average, the inflammatory stage is going to be 4 to 6 days, but it could last 10 to 14 days. The proliferative stage is going to be usually about 2 weeks, but might last out to 4 weeks. And then remodeling can take out over a year. There are studies that show that that continues out over 12 months. So we need to be somewhere far enough along the remodeling stage to really generally see a visual difference when we're rescanning somebody. So it takes a little bit of work to change that mindset and focus on the function more so than the strict anatomy.
Yeah, I think that's great. So if anybody's listening, watching, and they've been told that they have a tear, that tear doesn't have to totally heal. That herniated disc doesn't have to totally heal. You can get your function back. You can get your pain down. And you can feel great, and maybe don't get so caught up on that image. So I think that's great. So I think sometimes when two clinicians are talking, sometimes we like to nerd out and we get a little high level. So one way I like to reframe it is, can you tell us a success story you've had recently of someone maybe with shoulder pain or something else that maybe wasn't able to be helped elsewhere? And how did either ultrasound or injections, how were you able to help them?
Yeah, I'll give two examples because they hit on different parts of this. So let's take an even further zoomed out view first. I see a lot of shoulder. I like treating shoulder. The shoulder is complicated. Blame our maker, blame our evolution. But when we became an upright being, the structure of our shoulder versus our hip, even though these are both ball and socket joints, the hip is intrinsically a much more stable joint than our shoulder. We developed so that we could put our arm in space. We could throw, the initial forms of weapons as hunters and gatherers in order to throw a spear or a ball, rock very accurately. In the way of evolving like that, our shoulder intrinsically became very unstable, and we rely on a lot of dynamic stabilizers to maintain our stability. So we've got the ball in the socket that is kind of like a golf ball on a tee. It's way too big for the tee. We've got a lip of tissue on the socket side. So I always do my fist in my open hand, but this doesn't fit because obviously my open hand looks bigger than the fist here. But on the socket side, we have a lip of tissue called the labrum, which is kind of like cartilage. It really isn't cartilage, but it's kind of a cartilage-like structure that helps improve that fit a little bit. But then we rely on the rotator cuff muscles and tendons, which are 4 muscles, tendons of small muscles that support the shoulder from the front, the top, and the back. But then even beyond that, we have a multitude of muscles that attach to our shoulder blade, because the shoulder is more than this ball and socket joint. We got to think about the AC joint in the front of the shoulder, the sternoclavicular or SC joint at the base of the neck. And then there's the scapulothoracic junction, which is our shoulder blade sitting on the back of our rib cage. And the 17 or 18 muscles that attach to that scapular or shoulder blade, those are incredibly important for shoulder stability. So we have all these great physical exam maneuvers that have evolved over time to say, hey, if I put somebody in this position and test their strength, it should be telling me about a specific muscle and tendon in their rotator cuff, versus I change to this position, it should be telling me about something else. And there are some studies that have been done over time that try to look at the sensitivity and specificity of that. But the reality is we don't function as a collection of these individual parts. We are more than the sum of our individual parts. And the shoulder, more so than maybe any part of the body that I routinely look at, really depends on the interconnectedness of this system to function at a high level and at a normal level. So where that then has clinical utility is that it shouldn't just be and I want to make a quick distinction. This doesn't mean getting an MRI and calling every little thing that gets identified on the MRI as being part of the problem. But it really looks at, what it gets at is looking at things functionally in an integrated myofascial, from an integrated myofascial perspective, to understand what went wrong in the shoulder. So to get to your question, I give long-winded answers, I apologize. One of these examples is a little bit more straightforward. I had a patient who actually had a very significant partial thickness rotator cuff tendon tear. They were high performing, they were a regular avid weightlifter. It started with just trying to focus on the physical therapy side of things, saying, hey, you're not distinctly weak in that tendon. You're having pain with your pressing and overhead activities. Let's try to rehab this. Let's try to work on the strength and stability of the cuff and on the periscapular muscle so you have greater scapular stability. And let's see where we get to. And they were very dedicated to that program. They really put in a good hard effort. And only after 3 to 4 months of still not seeing the progress to get back to what their ultimate goal was from a bench press and overhead press perspective, did we then say, hey, let's go after it and treat these rotator cuff tendons. It was predominantly the supraspinatus, but a little bit with the infraspinatus as well. And we treat it with PRP in order to try to give it that extra push. And they actually responded really, really well. Does the tendon look perfect on our follow-up imaging? No, it doesn't. But this served as the extra push to allow them to better engage and strengthen that rotator cuff to where they're now better tolerating their overhead press and bench press maneuvers. So that would be the more straightforward approach in that, hey, we targeted the tendon that looked abnormal. But in another case, this patient came to me with more what seemed to be AC joint, AC ligament related pain. They would point right to their AC joint. That's where their pain was. It was uncomfortable when they would lie on their right shoulder, and we conceived that, okay, you get that compression on that side, so it squeezes that AC joint together a bit. And they were a pretty avid swimmer, so when they were swimming and did a lot of freestyle, the overhead stroke was painful as well. And they had a little bit of AC ligament degeneration, a little bit of arthritis at the AC joint, where we could see that the ends of the joint were a little bit irregular, not smooth, bony surfaces. And this was an older individual, so it's not unexpected to see some of this change. And in addition to those findings, what we also uncovered was that there was quite a bit of tenderness actually further down than that, really in the pec itself, in the pec major. And with looking with ultrasound, what we were able to pick up on was that there were tiny little splits in the pec major attachment along the collarbone, along the clavicle. And that's not something we commonly think of. I mean, you think of a big traumatic injury to the pec where someone gets under way more weight than they've tolerated before to do a 1-rep bench press max and tears their pec major tendon where it attaches over on the arm, or a contact athlete, let's say, making a tackle where all of a sudden the arm gets pulled into a dramatic extension and that pec was contracted, so that eccentric contraction tears the tendon. But this was actually at the muscle attachments up along the collarbone, and that's not something we commonly think about or are, let's say, normally trained to look at as a common site of injury. And it turned out that it wasn't until we started targeting that with some prolotherapy, which is a regenerative medicine technique that doesn't fit under the diagnosis of a biologic, but has some restorative, reparative capabilities. Treating that with prolotherapy made an enormous difference for them. They were able to return to their swimming. It took a couple of treatments, but they were able to ultimately return to swimming. So it was the bigger point being, we can't just be hyper-focused on, hey, this one exam maneuver causes pain and our textbook teaches us that it's this or it's that. It's looking at the shoulder as a full unit. And I'm a huge proponent. I take pride in writing my physical therapy prescriptions. I think too often it is eval and treat. And that's it, as opposed to saying, hey, we want the physical therapist to do their evaluation and give their input. As a physical therapist, you're an expert in therapeutic exercise, but the doctors writing these prescriptions should demonstrate, I believe, some degree of thought and transfer of information as well. And essentially all of my shoulder rehab prescriptions that I write, I want some degree of scapular stability added in, particularly focusing on those mid to inferior trap and rhomboid attachments where again, many patients are weak just from postural ailments of using computers and cell phones where we're rounded forward and with the shoulders and the forward stooped head position, we want to get things back into retraction and depression. So really looking at those periscapular attachments, I think, is a huge part of looking at the shoulder as a whole. I apologize. Another really long-winded answer for you.
No, that's great. I think both those stories highlight a couple things I want to point out. One is we find a lot of people they get an image, they see a rotator cuff tear, and they just automatically assume, well, I guess I'm never going to bench press again. I guess I'm not going to swim ever again, or they feel like their future is defined by their image. So I love both of your stories. Hey, we found these things on the image. One treatment option didn't work, but they were able to get back to bench pressing, able to get back to overhead pressing, able to get back to swimming. And I think that's great because way too many people think that they're limited because of their image. And then
Yeah.
the other thing I think is really important is a lot of people try one thing and they say, well, that thing didn't work. So they might, we have people all the time. Like we have a lot of people come, they try three other physical therapists, then they come to us. A lot of people will try physical therapy once and they'll say, well, physical therapy doesn't work. Or they'll try one type of injection and they'll say injections don't work. You offer a lot of different options, and if someone doesn't have success with something, it doesn't mean give up. It means there's so many other options that you can consider. And I think a lot of people feel, one thing didn't work, let me jump to surgery. And there's so many things that you can offer and we can offer that there are multiple steps in between trying one thing and then immediately jumping to surgery. So I think those two stories
Yeah.
are great.
Totally agree with you. And again, while what I do and the patients that most commonly seek someone like myself out versus what an orthopedic surgeon does, like there's a lot of overlap in terms of we can see and treat a lot of the same patients. But an orthopedic surgeon is going to be more likely to see the acute traumas, right? Like, so if someone dislocates their shoulder and acutely tears, let's say, a labrum, or they acutely tear a rotator cuff that it's torn right there and then it was otherwise perfect, it tore, retracted, or they separated their AC joint with a bad fall on the shoulder. That is different from what we see much more commonly, which is the kind of the chronic wear and tear, the repetitive stress and strain, where by the time that MRI is obtained, I think a lot of people's intuition is that this problem just happened. And the reality is that that problem was slowly developing over time, but it had not reached a symptom threshold point. And something caused them to cross that threshold. Maybe it was a fall, maybe it was, hey, something they did kind of off in the gym, or maybe it was just this was the gradual point where they were going to eclipse that threshold. So yeah, those changes are there. Sometimes those changes require some degree of direct treatment, but many times the treatment is going to be more aimed at getting them back down below the symptom threshold so they can function better.
Yeah, I think that's great. And then the other thing, I love that you talked about strengthening, scapular stabilization, all that. I think this is more me getting on my soapbox about my profession. I think oftentimes our profession, what we call underloads people, so we don't stress people as much as we give people credit for, or as much as we should give people credit for. So when we talk about strengthening a shoulder, if we're doing I's, T's, and Y's, that's great. But if somebody's trying to bench 200, 250, 150, if they're trying to bench, if they're trying to do overhead press, if they're trying to swim, if you're in shoulder therapy, your shoulder exercises should kind of match what you're trying to do. And way too often, what we find is people, the beginning exercises are great, but we don't stress people enough, and we just need to push people a little bit more to get back to kind of what they want to get back to.
Yeah, that makes total sense. Let me turn the table a little bit and ask you a question because
Yeah.
I think a place where we run into a huge gap. We like to talk on the orthobiologic side, the treatment gap, where we talk about somebody who with osteoarthritis has kind of failed the standard of care. They're not ready for a joint replacement, and in that spectrum is where the orthobiologics come in as this extra push. I see on the therapeutic exercise of things side of things a gap where exactly what I think you're hitting on. Like you start off with the kind of the basic stabilization program. Let's get these stabilizers going. But then before you can get the patient back to that full higher level of activity, insurance will cut off their visits or the patient, quote unquote, gets discharged from PT, and then they can't make their full return where there'd be this great opportunity to step in with continued therapeutic exercise to kind of walk with the patient hand in hand at that next level to achieve at those higher functional levels. So I'd be curious to know your thoughts about that because I tell patients all the time in the perfect world, like I would see it going from, okay, things are flared up right now. You're going to start with this more regular PT and over time, your visits might get more and more spread apart, but you're continuing to work with your therapist in order to make these ultimate longer term gains and achieve what you're trying to get back to from a full function standpoint.
Yeah, I mean, I couldn't say it better myself. That's the entire reason I started our company is because there is that gap. People will, they'll get 40% better, 60% better, but that doesn't mean that they're back to doing whatever it is that they want to do. So there's a huge difference between feeling better and your shoulder or knee or whatever being ready to get back into running or the gym or swimming or things like that. And I think what happens is a lot of times people will start to see progress and it'll stall because in general, my profession right now is not great at uh, higher level strengthening. So there's this treatment gap of we're great at the I's, T's, Y's, basic band strengthening, but we're not necessarily educated enough in the higher level strength training to get people back to where they want to be. So we've got a ton of CrossFitters, and we're doing CrossFit style movements in their sessions. I had a football player a couple years ago. We were going through his therapy session, and there was somebody else in the gym, and they looked at him and they asked him. They were like, "Are you doing physical therapy right now, or are you doing personal training?" And he kind of looked at him crazy, like, well, "I'm doing both. What do you mean?" I just think there's a big gap. We had somebody, he came in. He was dealing with back pain actually, and he was back to deadlifting 300 pounds, but he was deadlifting 400 before. So he got to 300 pounds, and his physical therapist was like, "All right, you're good." And he was like, "What do you mean I'm good? I'm not. I'm 75% of my recovery." And his therapist was like, "No, you're deadlifting 300. You're fine." And he was really frustrated because the therapist didn't have ways to get him back to where he wanted to be. And so we worked with him and said, "Okay, this is where you are. This is where you want to be. So we need to develop our exercise plan to get you from here to no matter what your goal is. You can always get more strength. You can always get back to where you were before." So I couldn't agree more that there's a treatment gap. And not to be long-winded myself, but that treatment gap can be, even if you're not trying to go from 3 to 400 pounds. I had somebody else, she had 4 knee surgeries. She had seen 3 physical therapists. She came to me and she was, quote, graduated from physical therapy, but she came in crying to me because she couldn't even walk 4 blocks without pain. And they basically told her, you're as good as you're ever going to get. And I said, you've had 4 surgeries. I don't know what your ceiling is, but I'm pretty sure it's more than what we can do now. And we developed a really thorough strength plan that started at her good entry point and then slowly like really pumped her up. I just saw her 2 months ago. She ran a half marathon, and people
That's
told her
awesome.
she was never even going to be able to walk without pain. So I think it's that treatment gap that's a huge problem in my profession right now.
Yeah. Yeah, no, well said. I appreciate hearing the insight from your perspective because
Yeah.
it definitely, I see those shortcomings myself when patients are trying to find that next step to make that ultimate full recovery, right? Like there are the scenarios where somebody has a first time low grade ankle sprain and over the course of a few weeks they bounce back and essentially feel like they were beforehand. But inevitably with the type of work we do, the type of patients that will gravitate to finding us it's those that are falling into a form of treatment gap of one sort or the other.
Yep. Yeah, I always tell people like I use back pain because everybody has back pain at some point. And I say, if your goal is to get back into the gym or running or whatever, bird dogs and planks are great, but it just doesn't get you back to the level of strength that your back needs to get back into the gym. So whether it's your shoulder, your knee, your back, just make sure that your strength program or your rehab program kind of mimics what you're actually trying to get back to.
Yep. Makes sense.
So I think that's great. So a couple things to finish up on. You had mentioned, and I think this is a really important thing to say. Let's say somebody has an MRI, it showed them rotator cuff tear, labral tear, whatever it is, and you kind of said that people they can hyper focus on it, and I think that's I think it's really really common. It's really easy to see this image. Oftentimes they are told by a doctor, "Wow, your MRI doesn't look very good," or they say, "Man, that's a lot of damage in there." So it gets really scary to hear these words: tear, degeneration, fraying. All these things are very scary. So what would you say to that person who's a little bit anxious about their MRI? They're not sure how much better they can get because they've been told they have this thing on their MRI.
Yeah, I think let's focus on the word tear. Tears come in all form, shape, sizes, and not all tears are created equal. So somebody who suffers in general, we'll generalize a little bit here. If they suffer a full thickness tendon tear, particularly if there is retraction, meaning you think about the old cartoon where the tongue rolls up, so like the tendon tears and now it's rolled back. In many instances, that is going to be a relative surgical urgency. They need to be seen by an orthopedic surgeon, evaluated, and there are other things that will get looked at in terms of how old are they, what is their overall function level, what are their medical risks. But that is probably the best candidate for a surgical reconstruction or repair, probably reconstruction when we're talking about a full tear. in terms of what their functional decline will be if that's not addressed quickly enough. Short of those acute full thickness tears, most of these other tears are going to be things that can be monitored and rehabbed and more addressed in a sequential manner as opposed to having to jump to something super invasive. So we'll think about low-grade tearing or fraying, which might mean that there's just small little defects within the tendon. There can be partial tearing, which means if my fingers are representative of the the tendon, maybe half of the tendon in one direction or another has a partial tear, but there's still scaffolding in place that is still allowing you to transmit force from muscle through tendon and fascia to bone. Or to other muscles. Some muscles attached to other muscles. It's not all just the very simplified version of anatomy we were all taught of muscle to tendon to bone. It's more complicated than that. Some are interstitial tears or split tears, which means that it's not that the attachment site is torn. It's that within the tendon there can be a defect that runs lengthwise through there. And all of these can behave differently. Some of these can be extraordinarily painful. Some of them you've had for years and never even knew about it, and they don't cause any pain. So it's all about, I hate to sound like a broken record and boring, but it all comes back to assessing somebody's overall presentation and their function to determine how relevant is this tear, and is it something that, hey, we can more or less ignore and focus on pure rehab, or is it something that we want to try to address with some degree of intervention, whether it be an injection or something else. So they come in different shapes and sizes, and if you get a good radiologist, they're going to call a lot of stuff that they see there. That is their job. Their job, I value radiology reports. I look at the imaging myself and make my own interpretation, but I value what the radiologist does because they went the same way I went through full residency and fellowship training to do what I do. They went through full residency and sometimes fellowship training to do what they do. So they're great at picking out the abnormalities on the picture. Then it bounces back to us as the clinicians that are seeing the patient, because they don't get the benefit generally of examining the patient. We pull from there what seems to be most relevant based off of how somebody actually presents.
So that brings up a point. I use this analogy all the time, so I would love for you to tell me I'm wrong and challenge me here a little bit. I always tell people, if we have 10 people, 5 have shoulder pain, 5 don't, and they all get MRIs, we put 10 MRIs up on the wall, we wouldn't be able to pick which 5 from the MRI have pain and which 5 don't have pain. I use that analogy all the time. Tell me I'm wrong.
You're 100% right, because this study was actually done for lumbar spine MRIs. They took 100 patients that had no back pain whatsoever, took MRIs of their lumbar spine for all of them, and the goal was for the most seasoned neuro or orthopedic spine surgeons to say, okay, line these up in the order of least pain to most pain. And it didn't correlate because, again, these were individuals that did not have pain, and you will find a multitude of abnormal findings on these studies. So again, we all will accrue dings and dents over time. They're not all super relevant and warranting or in need of direct treatment. So you're spot on. I mean, the person is more than their picture. And the other thing, again, not to like super nerd out on this, is so much of those pictures are born out of what our traditional teaching of anatomy, where that comes from. Again, it's the joint, it's the bone, it's the muscle to tendon attaching to bone. There's a ligament attaching from bone to bone. When as an integrated myofascial unit, we're not even talking about the fascia on those imaging studies. The fascia envelops muscles and tendons. It actually is, if you go to the silly kid song, the head bone connected to the knee bone, like that's what helps integrate and connect our body as a single unit. And it's really looking at it from that perspective that enables us to unravel a lot of these, let's call them mysteries of why does this person hurt and that person doesn't, with similar looking MRI findings of the tendon or the joint, et cetera.
Yeah, that's great. I think that's an awesome message to leave people with is you are more than your image. No matter what your image shows, you can get out of pain. I had somebody a bunch of years ago, he had 2 full rotator cuff tears, 360-degree labral tear, thought he needed surgery, and he's back to golf today. So I just think you're more than your image. There's tons of treatment options. Prolotherapy is great, PRP, stem cell. There's all these options out there. So no matter what your image shows, you can get out of pain. So Mike, this has been great. I know you just opened up your new practice. So tell us, what's your new practice? Where can people find you?
I appreciate the ability to give a shout out. New practice is Impact Sports and Spine. We are located in Rockville, Maryland. Very easy access. Well, we'll use the word easy relatively. It is the DMV. We all are used to the traffic, but we are very close off of 270. So for a lot of the patients that and contacts we've made over time throughout the DMV, we are accessible by the highway. It's myself and my partner, David Itzkovich. We've been practicing functional sports medicine and spine medicine with a function focus in terms of regenerative orthopedics and that whole niche. But we're function focused, and we've been doing this for the last 6 and 7 years in the region, and we've been in our own spot here for the last 2 months, and we're here to help. And I could nerd out and talk about this stuff for a long time with you. I appreciate you giving me the amount of time that you did.
Yeah, of course. What's your? Do you have a website?
Yeah, so we can be found on the web at impactsands.com. So that's S and S as in sports and spine. But writing impactsportsandspine.com seemed like a mouthful, so we got it shortened. So it's impactsands.com. And we're happy to see new patients. We're happy to see old patients.
That's awesome. Thanks so much for joining, and congrats on your new practice.
Appreciate it. Thank you very much.